to see. Good morning. Thank you for being here. We are so pleased to have Tim Bryant with us. Bully has been kind enough to get this organized for us, so we are so thankful, and thank you for coming.
It's good to be here again. After this program, we are conducting registration for the Winter Bully session in the main common area, and we'll be there till about noon today, and then we'll come back the week after Thanksgiving for another time of registration. But we're glad you're here today. I think you're in store for a great presentation, be quite informative. We have Dr. Vanessa Schaefer with us this morning. And Dr. Schaefer is a clinical geropsychologist with over 30 years of experience dedicated to supporting individuals through life's transitions, now specializing in the mental health and well-being of older adults. She offers personalized consultations designed to develop strategies and skills tailored to each person's unique journey of aging. Her approach empowers people to navigate opportunities and challenges with resilience and purpose. In addition to her private practice throughout her career, Dr. Schaefer has collaborated with medical centers and psychiatric hospitals. Her expertise in working with those facing chronic and terminal illnesses is characterized by an exceptionally knowledgeable and compassionate approach. This morning, we welcome Dr. Vanessa Schaefer.
Thank you so much. Good morning. It's weird to hear somebody describe you, you know. I'm exceptionally compassionate. I'm going to tell my husband when I get home. I don't think they know, Tim, did they know that I'm a pinch hitter? Did they know somebody else was speaking? Doesn't matter, but I have to tell you the funny story. You were supposed to hear from my colleague and good friend, Dr. Marshall Bruner, who's a remarkable psychologist in town, who called me and said, V, he calls me V, I have a problem. And I said, okay. And he said, I committed to speak at Lanier Village and I love it there, but I can't make it. And he never doesn't do what he says he's gonna do, never. So I was like, Marshall, what is it? Is it a surgery? What's happening? And he said, it's a ballet. I said, what? The ballet. I said, are you saying the word ballet? And he said, yes. And I said, you're going to the ballet on Friday morning? He said, not exactly. I said, okay, Marshall, I'm a therapist and I don't understand a thing you're saying. And he said, I'm in the ballet. I said, oh my, okay, what? And he said, the Gainesville Ballet Company's production of The Nutcracker, it's my daughter's last year dancing in it, and I'm in the production, and I can't let her down, and I have to do the ballet. And I said, I know he doesn't drink much, and I know he's, it's 8 o'clock in the morning, and I said, Marshall, from now on, for the rest of my life, the only reason I'm ever gonna substitute for somebody is if they're in the ballet. So, Marshall isn't here, but I'm gonna try to make him proud today. Yes, I believe he will.
Our next program here will have Marshall Bruner all decked out in his ballet.
He's going to be delighted that I told on him. So go if you're going. I tried to get tickets for Sunday afternoon. It's already, I think there's like one seat left, and I was trying to take friends. Anyways, I'm going to try to do Marshall proud. Like Tim said, I am a clinical geropsychologist. After 25 years of private practice, I became recertified in geriatrics and exclusively work with people 65 and older or people of any age who provide care or support for them, and it's just been the best part of my career. Older adults are considered individuals age 65 and older. I'll be that in 2 years. I'm excited about it, can't wait. And I do therapy with older adults, and I do consultation with families and older adults about any issue related to aging, including I've been lately doing a lot of consultations for optimizing people's experience of aging, physically, emotionally, psychologically, socially, spiritually, and it's fantastically enjoyable and rewarding. I'm going to speak to you today about a topic that is not really light and fluffy. It's not ballet-ish. It's a serious topic, and hopefully there's some information in here that's helpful to you or somebody you love, somebody you know. When we talk about dementia or substance abuse or mental illness in older adults, we're really talking about quality of life, basically. These issues affect the quality of our thinking, how stable we feel emotionally, how safely and independently we can live, and whether we lean in or pull away from people in our social environment. The title of this talk is not, as I said, fluffy, but it reflects real life for many older adults and their family members. And the conditions overlap. I'm going to make an argument that we as clinicians and diagnosticians need to be really knowledgeable and careful about not just assuming things. These conditions look similar and they get chalked up. Well, they're sad. Of course they're sad. They're 95 years old. Wouldn't they be sad? There's just a lot of loss. Or memory challenges get blamed on stress or frustration, or, well, I'm 85 years old. What do you think? Can't remember everything. And medication misuse or alcohol misuse really gets overlooked in an older adult population because it feels familiar. Oh, he's always had a few drinks in the evening. But how it affects us later on is where the tricky territory begins. So my goal this morning is not to turn you into diagnosticians, because I still need the job. So it's to give you a clearer map. When we understand these conditions better and how they interact, what happens is we're less likely to blame aging, which is ageist, and we're less likely to blame ourselves for not handling things well, and we're more likely to ask the right questions sooner and get intervention, the right kind of support for ourselves or our loved ones. When professionals like me evaluate older adults, it's critical to remember that depression, dementia, and substance abuse can look remarkably similar, like triplets almost. Each can cause slowed thinking, social withdrawal, poor motivation, and memory deficits. So at first glance, they're almost merged. They almost look right on top of each other. The challenge is that the treatment plans are different. What we do for somebody who has a diagnosis of a dementia disorder and what we do for somebody with a diagnosis of depression are worlds apart. They're separate, right? A person with depression may show, and often does, show significant improvement after treatment, where for somebody with early dementia, we're not going to greatly improve their memory or their cognitive ability. We may slow the decline. So about 20% of people 65 and older experience some type of mental health concern. And most older adults don't seek help for mental health issues, and if they do, they primarily receive them from a primary care physician and not necessarily a mental health specialist. The most common mental health disorders are depression, anxiety, insomnia, and substance abuse. Seeing the numbers, I don't mean it to be doom and gloom, it's just a reminder. Mental health concerns in later life are real, and more importantly, highly treatable when they're diagnosed correctly. We're going to start with depression. We'll start with the mental health. Depression. 50% of the cases of depression occurring in an older adult is a first occurrence, meaning they have never previously been diagnosed or experienced similar symptoms. And this matters because a lot of older adults who eventually get to me say, this should not happen now. If you could think, if you knew all the things I've gotten through, all the stresses, all the changes, all the transitions, why in the world am I having this now? Highly treatable. I say, well, we can spend all our time trying to figure out why, or we can get it treated. And they usually vote for that. Depression, and this is critical, is not a normal part of aging. I have had on more than one occasion, and I'm a big fan of the medical profession. I'm on the staff at Northeast Georgia Medical Center here, and I tend to like doctors, but I do not like when doctors say to me, well, she's 86 years old, Vanessa, what do you expect? And I say, I expect you to act like they are not just an age. I expect you to act like they have people that love them and things that matter to them, and I expect you to treat them, and if you won't, we'll find somebody who will. So I might not be the most popular member of the staff. I don't care. If symptoms appear, it's a signal to evaluate. It's not just a sign of decline and, oh, there's another brick on the pile, right? Untreated depression increases an individual's chances of developing a dementia disorder. That's also true of anxiety. Untreated mental health issues increase a person's propensity to develop a diagnosis of dementia. That's reversible. That's a reversible factor. Okay, late life depression rarely appears out of the blue. It usually develops in the context of several things. It can be widowhood. That's number one on the life event scale for stress, losing one's partner, number one. Physical illness that was not previously diagnosed. Impaired functional status, something that you used to be able to do entirely independently, you are not able to anymore. Social isolation and loneliness, profound, that I should have put that number one. Heavy alcohol consumption, other functional limitations that might make life difficult for people. Sleep problems, and being sedentary, not moving. If you're able to move, not moving, not good. It usually develops in the context of accumulating factors here. The more of these risk factors a person is living with, the more important it is for us to screen proactively, not just view it as a function of getting older. Some other specific causes, hereditary, it has a huge hereditary component. Stressful events, unexpected especially. Retirement, which is a change in the fiber of the structure of what we do with our day and how we define ourselves. What do men ask themselves? What do you do? What did you do? What did you retire from? Women, do you have children? Health problems and reactions to medications. So when we're combining some of these things, have a greater risk to develop a mood disorder. The presence of a depressive disorder, whether it's diagnosed or not, often adversely affects the course and complicates the treatment of any other chronic disease a person is living with. And for people over 65, I think it's 65% are living with one chronic disease, and over 70 individuals are living with 2 or more chronic diseases. So, in other words, when depression is untreated, conditions like diabetes, heart disease, COPD, those sort of things, are harder to manage, and patients tend to have poorer overall outcomes. It has been my experience when I switched, I'm used to people coming to me because they're depressed or anxious, right? Like, that's part of the reason I'm here. But when older adults began to start seeing me, they wouldn't necessarily talk about their mood. They would talk about distress in some other terms. And I began to figure out that because of strong negative prejudice and discrimination associated with saying you're depressed or anxious or have some other mental illness, people would be resistant to saying that this was the problem. And stigma is not just harmless discontent, right? It's not just, it keeps people struggling and it keeps them unseen, living with symptoms far longer than they have to. I recently did some work with a woman who was notably depressed, and her son said to her, you know, you're just a little sad, like you're complaining a lot, and why don't you just, in effect, pull yourself up by your bootstraps? So she shared that with me. She was really reluctant to go. She came to me, but she wasn't going to do what we were talking about in terms of treatment, and then she shared with me that her son was critical that way, and he's a fundamental part of her life and her care. And I included him in one of the sessions, and once I educated both of them about the causes and the symptoms of depression, they were both on board. She's gotten beautiful treatment, and she's thriving. So sometimes it's just a little bit about teaching ourselves and other people about what is normal but a problem. So the prevalence, depression is less common in healthy community-dwelling older adults, and by community I mean their own community, their neighborhoods, their homes with their family members or loved ones. The rates climb sharply, as you see, when people are hospitalized. Untreated depression leads to more hospitalizations overall. When they're receiving home health care and in long-term care. Wherever older adults are more medically fragile or needing more care in any way, we need to carefully consider whether depression might be part of the clinical presentation. You see 1 to 5% of people living in their own homes and 14 to 42% of residents in a long-term care community. Okay, some of the common symptoms, and these are some but not all. Persistent, sad, or empty mood, feeling hopeless, worthless, helpless, overwhelmed, guilty, feeling irritable, restless, having trouble sitting still, loss of interest from activities that people used to enjoy, including intimacy with one's partner, withdrawing from regular activities that people used to really enjoy and participate in regularly, moving or talking more slowly, feeling slowed down. The symptom is actually called psychomotor retardation. And a patient years ago described it as, she said, you know those, I don't think they still do this at the dentist, but those mats, those lead aprons they used to put on you to get x-rays, she said, I'm wearing 10 of those all day, every day. I'm dragging myself through the day. It's really a great image. Lasted 30 years in my head, so. Difficulty concentrating, this is the cognitive triad. Difficulty with concentration, attention, memory, making decisions gets really hard. People say, I used to be able to decide like this, and now I just don't know what to do. Difficulties with sleep, including problems falling asleep, staying asleep, waking up frequently, oversleeping. Somebody told me recently she spent 3 solid days in bed. Physical symptoms like pain not related to a diagnosed chronic condition. A lot of times it's GI problems for people. Eating more or less than usual with unintended or unplanned weight loss or weight gain. Thoughts of death or suicide, or passive or active suicide attempts. A decline in personal care, that's not showering or bathing, not getting out of one's pajamas. I'm an advocate for spending 1 whole day in your pajamas once a month. I think that's a luxury and delights me, but more than that, not so good. And hallucinations or delusions. Delusion is believing in something that is not true, and a hallucination is seeing or hearing something that other people do not see or hear because it is not there. When depression goes untreated in an older adult, they have more medical problems overall. This is an evidence-based presentation I'm giving you, so all of the statistics are coming out of psychiatric and psychological literature. It's not my personal opinion. So they stay longer in the hospital. When they are hospitalized, those visits last longer. They will need to use more medication for medical problems that they're being treated for. They have more visits to the emergency department, and they experience more loneliness and isolation. There are so many consequences, significant consequences for untreated depression, and there's so many of them are really compelling to get treatment. This is a hard slide, but the truth of the matter is that individuals with the highest rate of death by suicide are white males age 85 and older. When I query people about what age they think has the most death by suicide, they say 18 to 25. That's a myth that we carry around, that teenagers are so unstable. Teenagers do die by suicide, but not at the same rate as this cohort. Professionals use what we call the 5 Ds of late life suicide: disease, having a diagnosis, disconnectedness, depression, disability, and having deadly means. Disconnection has a lot of negative health outcomes. People have a very high risk for suicide when they begin to believe that they have become so much of a burden to someone or a group of someone's that others would be better off when they are gone. And this is not this is not in this slide, but I want to say this, and I say it every day in my practice. The quality of our life is most closely correlated with the quality of our relationships, period. If I could get people to change one thing in their life, it would be to connect with somebody. I have people who say to me, and I don't see people weekly, I I just have a very small number of therapy patients, and I am unable with my schedule to see them weekly. I have people who say to me, I haven't spoken to anybody since we last met. And I am like, walk outside your front door, turn left, go to the next front door you can find, do this and say hello. And then sometimes they do, and it helps. It is the longest running psychological study that's ever been undertaken was the Harvard study. It's almost 80 years old. And they were looking at young men in Boston. They were looking at sophomores at Harvard and young men, indigent young men in Boston, thinking they would figure out what made for a happy life and people, what would make them psychologically well. They were sure it would be money and education and opportunity, and it wasn't. It was the quality of their relationships, right? A man's longevity is most closely correlated with the quality of his marriage. A woman's longevity is most closely correlated with the quality of her friendships. Sometimes my best friend doesn't live in Georgia. He'll say, how long till you're going to see Kathy again? Which means I'm talking a lot, and he needs a rest, and I need my girlfriend. Okay, according to the Centers for Disease Control, 80 to 90% of cases in older adults, cases of depression, are highly treatable. It's critical that we ourselves, within ourselves and among one another, challenge the false belief that depression is in any way a normal part of aging. It is not. We also need to challenge the ageist belief that people are too old to change, to do anything different, to go to that neighbor's house and knock on the door, to take a medicine they haven't taken before, to get a little exercise if and when they're able, right? Also, it's not okay to think that by virtue of their advanced age that they don't deserve to feel better than they do. I also would note that depression is highly treatable in the context of a dementia disorder. We'll have people who are diagnosed with dementia who are then exhibiting symptoms of depression, and we can alleviate that mood disorder. It does not change the course of the dementia, but there are a lot of people who have an interestingly good quality of life with dementia as they're having the journey. Okay, anxiety's up next. Anxiety is among the most prevalent mental health conditions among older adults. Almost half of people 65 and older who are diagnosed with a depressive disorder also meet the criteria for an anxiety disorder. Anxiety, by the way, runs in my family. And many years ago when I asked my mom, I heard her saying that to somebody on the phone. And later I said to her, anxiety runs in our family. And she said, oh, it doesn't run. It runs marathons. So all the women, all the way back. Okay, some of these symptoms, right? Everybody experiences it differently. I shouldn't say nobody. Most people don't have all of them. Some people have many or most of them. Some people have one or two of them in spades, and then not others. So shaky, panicky, difficulty breathing, shortness of breath, sweating, nausea, dizziness, feeling lightheaded. This is all outside the context of any medical issue, right? You have the stomach flu, it's not anxiety. Headaches and confusions, eye and vision problems, muscle tension, soreness, fatigue, irrational thoughts, forgetfulness. What is that like? Dementia, right? Irritability, avoiding people, places, activities, even avoiding thinking about things that trigger somebody's sense of anxiousness, changes in weight, appetite, or previously normal eating habits, not wanting to leave home, becoming isolated and withdrawn, having obsessive thoughts or compulsive behavior. I once had a massive panic attack. During my internship, we were required to present at grand rounds, and so the only symptom I had was I'm having a heart attack. And I thought, oh, 400 doctors out there in the audience, I bet I'll make it through. Not a weird thought, not a shaky, not a nothing, just I'm having a heart attack. But I wasn't. Okay, anxiety can be overlooked or underestimated because older adults, again, are less likely to report psychiatric symptoms, and they're more likely to emphasize physical complaints, which sends us as professionals down the wrong path. Let's figure out what illness it is. What do they have, not what's having its way with them, right? Late life anxiety is not as well understood in our research, but it's believed to be as common in older adults as it is in younger age groups. Just like with depression, Untreated anxiety is associated with poor health outcomes, including greater propensity for a dementia disorder, more poor physical health, increased disability and impairment, a report of a diminished quality of life, and increased caregiver stress. I'll say this, a lot of times the person who approaches me is the loved one, spouse, partner, caregiver of somebody, and living with somebody with untreated mental health issues is really stressful because you can't, it's an inside job. Can't get fixed outside. You can't make enough soup or rub enough feet or say enough uplifting quotes to make what's happening clinically, chemically with our mood better. And so it's really hard to watch. It's frustrating to live with. It's very overwhelming. As overwhelming, as significant as living with somebody with a long-term medical issue. Like depression, anxiety is highly treatable in older adults. When we name it clearly and offer evidence-based care, people say that they are sleeping better, they can think more clearly, they re-engage in parts of their life that they had withdrawn from. Untreated anxiety drives the overuse of medical services and fuels depression, so noticing it early shouldn't be an afterthought. We shouldn't look secondarily. Okay, studies show that choosing an evidence-based therapy, meaning well-researched with good outcomes, is the best way to recover from depression or anxiety and prevent relapse. These are some of the forms of therapy we use. Cognitive behavioral therapy, that's when we don't necessarily focus entirely on what's happening, we focus on what people are telling themselves, the thoughts they're having about what's happening. Problem-solving treatment, literally looking for a solution to a problem that is causing distress. Interpersonal psychotherapy, which is about our relationship with ourselves and significant others. Reminiscence therapy, one of my favorites, that involves storytelling on a person's part about challenging and rewarding episodes in their life that have helped define them. And the use of antidepressant medications. The gold standard for treatment for depression and anxiety in any age is a combination of pharmacotherapy and talk therapy of various types. Okay, next section. I want to shift our attention to substance abuse. It's an area that's widely overlooked in older adults. When I see a new older adult in my practice for consultation or therapy, I ask them, I don't say, do you use alcohol? I say, how much alcohol do you use? And sometimes they say none, and that's true. Or how many substances do you use? How many prescription medicines? How many supplements do you use? They say to me that their physician, some people say, has never asked them, not ever once. Okay, 65% of people 65 and older, 65%, you guys, report high-risk drinking, which is defined as exceeding the daily guidelines for alcohol use at least weekly in the past year. Binge drinking is defined as 5 or more drinks on one occasion for a man and 4 or more for a woman. And remember this, alcohol, 1.5 ounces is a drink, right? People are not measuring, I'm telling you. 1.5 ounces of liquor, 5 ounces of wine, and 12 ounces of beer. They sell beer in cans this big. Have you seen those? I don't know. Okay. In older adults with medical conditions like diabetes or high blood pressure, among others, even 1 drink a day can be problematic. Using prescription medicine and alcohol together, even if they're several hours apart, impacts the drug's effects, both its positive impact, what it's supposed to be doing for it. I just saw one of my favorite people on the planet in the back of the room. I didn't notice you yet. Okay. It's important to note that symptoms of alcohol misuse are sometimes mistaken for aging or physical illness. It can also mimic or intensify the signs and symptoms of other illnesses. And as we age, our body metabolizes alcohol more slowly, stays in our system longer. So the old, it's been an hour since I had a drink, I can drive. Yikes, no. So the physiological effects, what is chronic alcohol use, what can it do? Affect our hypertension, high blood pressure, heart disease. increases our chance for a dementia disorder. It can increase our chance of a stroke. It impairs our immune system, our ability to fight day-to-day infections. Long-term use leads to cirrhosis or other liver diseases, decreased bone density, increase in chronic pain, internal bleeding issues, ulcers, depression, anxiety, amnesia, other mental health disorders, cancers of the stomach, larynx, pancreas, liver, or esophagus. When we see any of these medical issues, one of the top questions we need to ask, are you using alcohol? After age 70, most people are not just on one pill, right? They're on a regimen, what we call a regimen. About 4 prescriptions on average, and a third, 33 to 50% of people 70 and older are taking 5 or more medications. One study of 3,000 adults aged 57 to 85 showed common mixing of prescription medicines, non-prescription, like over-the-counter drugs, and dietary supplements. More than 80% of the participants used at least 1 prescription medication, and half of them used more than 5, putting at least 1 in 25 people of those 3,000 at risk for a major drug-drug interaction. I'm also astounded, since I got myself up and running to learn about what I needed to know to work with older adults, I'm astounded at how many physicians are using medicines, which I can't really comment on because they don't have a medical license, but I can make observations, are using medicines that are contraindicated for use with people 65 and older. We have something called the Beers, weird name, right? Criteria, which is a list of medicines not indicated for use in older adults, whether it's a combination of medicines or certain kinds. And I see they give me their drug list in their chart, and I read them, and I only say, I think it will allow me to speak to your doctor. I'd like you to speak to your doctor about some of the medicines you're on. Sometimes people come to me with what looks like they have a lot of falls, they have balance issues, they have foggy thinking, and we change, under the doctor's supervision, their medicines, and they clear up, and their balance is better, and they're back to their workout class, or they're going back to the pool. That's important. It's important that we look closely at what's happening for people. Alcohol is also a toxin to our brain. It reduces what we call our cognitive reserve. Our cognitive reserve is our backup, built-in backup capacity. It's fueled by a lot of factors, things like our education, how much stimulation we're getting. Are you playing Wordle, or are you just staring at the news? Are you getting physical exercise? Are you connecting with other people? All of these things are deposits into our cognitive reserve. And alcohol use and untreated mental health disorders and being sedentary and not relating to one another socially is all draining our cognitive reserve. So then what happens is somebody might have a TIA, a mini stroke, or a stroke, or bump their head, or a period of depression, and that cognitive reserve is draining. And now their chances of developing a dementia disorder are through the roof. This is what's protecting us, and so we have to be protective of it. I want to balance the picture, right, by looking at protective factors. What are the pieces of our lives that help us stay safer, more connected, and more resilient? You guys have access to a lot of them being in this amazing place. Access to housing, health care, availability of social networks, social bonds. You could go downstairs and sit in the lobby and you'd see somebody, right? Involvement in community activities, they offer a lot of things. Supportive family relationships. If you don't have living family, then supportive relationships. Education about the wise use of medicine, a doctor who will sit down, a therapist who will talk to you about all the dark corners and what's in there. A sense of purpose and identity, meaning-making activities. It does not matter what it is. It just has to matter to the individual. And the ability to live independently for as long as possible, hopefully forever. Okay, for the specific treatment of a substance abuse disorder, we use a hierarchy of treatments, right? So prevention and education programs, number one, like what I'm doing today, saying what the risks are, what the factors are. Educational programs are not just teaching about alcohol use, they're bereavement programs, retirement programs, how do I find some structure and purpose, wellness programs, involvement in mentoring and volunteering. One of the most positive things you can do for your brain is to do something for someone else. Therapy, when we get to therapy, can help with goal setting to change behavior, behavioral modification techniques, self-help manuals and journals, education about medication and alcohol use. So we go from educating people to maybe having an intervention, which is meaningful others, trying to persuade somebody that they care about them and things need to change. An outpatient program, inpatient or outpatient detox programs, and residential rehabilitation is the high level. This has been my personal experience, but it's borne out in the literature. Substance abuse interventions are effective with older adults. Once an older adult commits to stop drinking, they are way more likely than a younger adult to stay sober. It's remarkable to see. I don't know, maybe because people have gone through more. They've had to handle more things. I'm not sure, but it's very rewarding to watch. Okay, the third corner of my triangle is dementia, which reshapes mood, behavior, and decision-making in ways that can mask or magnify depressive disorders or substance use disorders. There's a false belief that dementia is normal as we age. Again, what do you expect, Vanessa? They're 70 years old. I'm going to get a badge and I'm going to wear that at the hospital maybe. Dementia is not a normal part of aging. Misunderstandings about dementia, especially believing it's a normal function of aging, have many families and professionals postponing diagnosis and care, which contributes to risk and hardship. So I want to say why. What the research shows us is the earlier a person is diagnosed with the dementia disorder, the more quickly effective resources are scaffolded around them, the higher the quality of their life, according to their own report, and the longer they age in place, staying in the place they wish to live. When we wait and we say, we'll deal with it later, you know, dementia disorders begin 20 to 30 years before we see the first symptom. And there are a lot of people who call it type 3 diabetes. Right? There are lifestyle choices. There's certainly a genetic component. For Alzheimer's, there's something called the APO4E gene. This is an interesting study. There's a woman who studies our view of aging, how much internalized ageism we have, and her research over 20 years shows that people who have a positive view of aging, even in the presence of possessing that gene for Alzheimer's, it has a 60% less chance of manifesting. Like, that's free, just a positive view of aging. People who have a negative view of aging in their 30s, oh, all old people, have a 60% greater chance of having a cardiovascular event in their 60s. I find that fascinating. Okay, what is dementia? It's a medical neurological disease which is caused by damage to nerve cells, which we call neurons, in the brain. People age 65 and older survive an average, focus on the word average, of 4 to 8 years after the diagnosis of Alzheimer's. That's a particular kind. Yet some live as long as 20 or more years. Symptoms are not, it's not just a disorder of memory. It's impairment with judgment, reasoning, time perception, being confused, and physiological changes. Because people can live years or even decades with these changes, recognizing the full symptom panel is critical for support and realistic planning. The risk of dementia it's not a normal part of aging, but the risk of developing it increases with advancing age. It's the 5th leading cause of death for individuals over 65, and there are 6.5 million Americans over 65 living with Alzheimer's type. 73% of those people are 75 or older. There's something called early onset dementia, and people get confused between early stage dementia and early onset. Early onset dementia is a dementia disorder that begins before age 65. It's highly genetic, and it tends to progress very quickly. Things like Pick's disease is an example. Early stage dementia is being in an early stage of dementia, okay? Those are different. In the general population over age 65, 5% of individuals have a dementia disorder. When you're over age 75, 19% of people have a dementia disorder, and over 85, 50% have dementia. God bless you. You're welcome. Dementia becomes more common as people move into their later 70s and 80s. So in any group of older adults, we would expect that people would be living with it. It's a cue for us to build dementia-friendly care and communication into our routine. It's not an invitation to just assume decline and, throw in the towel. On this note, I'll mention our local Beyond Dementia Coalition. I sit on that board as an advisory member. We just in September had our dementia symposium, and 400 people came to learn from various professionals in the field. I did a speech there about having hard conversations with people. Also, my shameless plug is that I've written, my friend is holding it, a workbook for people newly diagnosed with dementia. It is a sort of legacy book. It's not about advanced directives or medical wishes. It's just about things. A woman that I'm working with said to me, "I'm afraid I'm going to forget myself." And so that spurred me to write this journal. Wow, my friend says. Okay. You're welcome to look at it. We can pass it around and take a look at it if you're interested. There's multiple different types of dementia. The most common is Alzheimer's, which is why the term is used interchangeably but incorrectly with dementia. Clinically, we group about 6 or 7 major types, like Alzheimer's, vascular dementia, Lewy body, frontotemporal dementia we're hearing about right now because of Bruce Willis, and his wife is doing beautiful advocacy around that. The exact number of how many types there are, it depends on the classification system we're using, but the big takeaway is that dementia is an umbrella term. It's not a single disease. There are instances where dementia-like symptoms are not related to dementia. So you have to be able to know what to look for, right? In older adults, we can see some of the symptoms that are dementia-like without any progressive brain changes and no other degenerative brain disease. And things that can cause that are really severe cases of depression that are untreated, untreated sleep apnea, a delirium, which is an episode of almost psychosis, often happens to people when they're hospitalized and schedules are being woken up every 15 minutes and it's light and dark at all hours. The side effects of certain medication or the interaction of certain medication, thyroid problems that are not being treated, vitamin deficiencies, I think B12 is one of them, and excessive alcohol consumption. Unlike Alzheimer's or other dementias, these conditions are often reversible with treatment. I have somebody right now who's being treated for Lyme disease and cognitively is clearing up. Like, I almost can't believe what I'm seeing. So, okay, figuring out what's going on with somebody who's displaying symptoms that are not typical for them happens one step at a time. It's not quick. When I send people for a neurological evaluation or a neuropsychological evaluation, or just let's start with your doctor, they'll say to me, I've been to 4 or 5 appointments already, and it's taking forever. And although that's really frustrating, it's a good thing because that means people are looking at all the possibilities carefully. That just takes time. 12 to 18% of adults 60 and older have mild cognitive impairment. There is something called age-related memory decline. I myself have 63 years of things to remember. I am really good at Jeopardy, but I always say to my husband, pause it, because it's going to take me a minute to get it. And he's like, I'm never going to sign you up for the game. I get the answer, but like 4 answers later, right? 4 questions later. That's not abnormal, okay? If I could never capture the answer, then that's more problematic, right? And the worst thing you can do when you've forgotten something and you're trying to remember is to try to remember. Just say to yourself, it'll come back to me. And then usually it does, okay? People often dismiss early signs of dementia as part of natural aging, but again, delaying the diagnosis is harmful. We get the resources, they happen later. Even when patients mention memory loss or cognitive problems during routine checkups with their primary care doctor, these doctors may not always be able to detect what's happening. According to one study, 72% of doctors had trouble distinguishing between the signs of normal aging of the brain and actual cognitive decline. And it's important to note that 50% of people with mild cognitive impairment will never go on to develop a dementia disorder, and professionals should know that. Okay, so if we compare them, we looked at each of them on their own, and I want to put them side by side and see where they overlap and where they differ. This is what's clinically a very foggy zone, where depression, substance abuse, and dementia mimic each other. It's like they're imitating each other. Or they hide in plain sight, and we call it something else. And it's where assessment really matters. And it's where if you notice something, certainly in somebody that you're related to, married to, living with, care deeply for, are good friends with, people say, I don't want to say anything. Okay, well, a whole other speech there, but you know what? There's loving, kind ways to say, I'm noticing some things. Are you noticing anything? Let's talk about it. Let's figure it out. Okay, these are some of the similar symptoms that are present in each of the three conditions. A decline in mood, increased agitation. People say, because they're so crabby and like aggressive. Confusion, becoming less involved in typical activities, experiencing declined memory, trouble with problem solving and decision making. God bless you now. Irritability, feelings of guilt, having increasing troubles in relationships, more contentious, more argumentative, more withdrawn, or getting lost, wandering. Each of the conditions has its own characteristics, but a number of them overlap, right? So each can be present in all three, and it's really important to have as much information as possible. And one of the things that's important is to find out which symptom presented in which order. And sometimes people can't remember that just because I can't tell you what I had for lunch yesterday. Probably, I don't know, maybe I didn't eat lunch. Also, getting collateral history. So asking somebody that's with the person a lot, what did you notice first? What did it look like? When did you see it? When depression, substance abuse, and dementia collide, no single clinician sees the whole picture, right? We need medical, psychological, neuropsychological, social at the same table, so we figure out what's what. And then we drive treatment for that, right? When somebody's drinking, using substances heavily, they have to be sober for 6 months before they can be appropriately evaluated by a neuropsychologist. Okay, if you remember nothing else from today, please remember depression, substance abuse, and dementia are all actionable. They're not inevitable, they're not untouchable, and with collaboration with family and friends and professionals, we can change the trajectory for people's lives. We can improve the quality of their life. Okay. That's my talk for today. If something today caused you to have a question or you wonder something, call your doctor. Call me. I'm not accepting right at this minute new therapy patients. Oh yeah, we'll have questions. But I am accepting consultations, which is like 1 to 4 meetings where we just give somebody some direction and tell them how to get some help. There's also, either there is or there will be a sign-up sheet. I write a monthly newsletter. Doesn't come out on the same day every month. Oh, you already did it. People signed it. You get my free newsletter. I don't sell your email, and it's my opinion on things that are healthy for your aging process. Okay, questions, please.
Wait for the mic, please. Questions?
No.
Okay, we know we all need help. Ask a question.
Okay. Dr. Schaefer,
Sir.
in regards to dementia, what is the relationship between a traumatic brain injury, and I don't mean from, like wartime traumatic brain, I mean just from a previous concussion. Mm-hmm. Does that increase your chances?
It does. Any injury to your brain, any injury to what I said was cognitive reserve, lowering the cognitive reserve, would increase your chance for dementia. It's not an inevitability, though.
And the more frequent, I mean, if you have
Yes.
multiple episodes of brain injury,
Mm-hmm.
that's just going to up the level even higher.
Right.
Great, thank you.
Same thing with more episodes of delirium. That's why when people say, well, it's just a delirium from the hospital, I say go take your person to the ER, go to the ER and get it treated, because untreated delirium repeatedly, or TIAs where somebody's like, I'm fine now, and it might have been a TIA, more of those. Thank you for the question.
Anyone? Oh, right here, Strother.
Strother, do you have a question?
You see advertised on TV this med that's supposed to clear up your brain.
Yes, you do.
I
wish
can't
I
think
had
what it's
invented
called.
it.
Prevagen. And
I forget what it's called.
and it's got to be good because everybody on there brags about how clear their brain is.
Don't they?
Should I waste my money on that?
Please don't.
Okay.
I'm not supposed to give medical advice, but if I were just talking to my best friend, it says research backed. Do you notice that? Look up who does the research. Who funds the research? Who pays for it gets the answers that they want. If there's no clinical proof that it's helpful. Do you know what helps brain health? There's a great book by a neuropsychologist who's here in Atlanta, and she's actually on the staff of NASA. We're getting to be friends. She's really smart. Her name is Vanetta Dotson, and she wrote a book on Amazon, all over bookstores too, called Keep Your Wits About You. And she talks about things that improve brain health, and anything that improves your brain health improves your memory. You know the top 5. Exercise. Nutrition, don't eat crap. Sugar's really bad for you. Alcohol's a toxin to your brain. Move your body. Move it with somebody else. Have friendships and have something that matters to you.
Dr. Schaefer, you mentioned during your presentation that those who were identified with the gene for Alzheimer's in their 30s had a 60%?
No, everybody. So everybody who has a negative view of aging in their 30s has a 60% greater chance of developing a cardiovascular event in their 60s. Having a positive view of aging throughout your life, even if you have, at any age, the APO4E gene, decreases the chances of that gene manifesting. 2 separate studies. Does that make sense?
Yes. But I thought, what would be the treatment for someone who has the gene early in life? What would be the treatment for that?
Well, that would be a better question for a neurologist, but my best guess is, okay, so we know this. We know that when people need a little pick-me-up in the afternoon and they drink a Coca-Cola or they eat a cookie, off the tray in the middle of the day, it causes a glucose spike. And we know that every glucose spike you have increases your chance for developing dementia later. Not everybody who has dementia has, oh, sorry, I'm sorry. You had a cookie for breakfast, didn't you? Not everybody who has diabetes has dementia, but it's a much greater percentage, or insulin resistance. So what they're finding now is there are 10 or 12 practices in life in general that they just consider good for your overall health and your brain health. Exercise is number 1. All day long, whatever form of exercise you can do. Movement is medicine, right? Good nutrition, eating. Remember Andrew Weil 20 years ago, 25 years ago? Everybody thought he was crazy, the bald guy, at the University of Arizona. And he said the foods you should eat look a lot like the body part you're trying to protect, like walnuts look like your brain, and people were like, what? He turned out to be right. He said dark leafy greens, berries, everything he said was true. Like eat the perimeter of the grocery store. Yes, ma'am. Sir.
When I headed up the Parkinson's group here, the Parkinson's thing is exercise, exercise, exercise.
They're not wrong. Not wrong. Yep. I never was an exercise. I was a competitive ice skater when I was young, very young. So I was really active, and then I went to school and went to graduate school, and that's full time, and got married and raised stepchildren or whatever. And it's really in the last 5 or 6 years that I exercise every single day. When I have a friend here, and she noticed I've lost some weight. I've lost 70 pounds in 3 years, and that's because I do weight training 3 times a week and Pilates twice a week. And I'm not a bodybuilder. I mean, I'm not going to wear a bathing suit in front of any of you ever, probably. But it has changed my life. It has changed my balance and my strength and my mood and my attitude. And if I haven't worked out, my husband was like, "You didn't work out today, did you?" And I'm like, "No, I didn't." Yes, sir.
Oh, thank you, Mary Bob. I was wondering if you could mention some of the drugs.
It's not on.
Hold it up to your mouth, Alan.
Can you mention some of the drugs that you see as chronic offenders with older people as far as interaction causing problems?
I'm technically not allowed to, because I'm a PhD and not a MD. You can find the Beers criteria, BEERS criteria, online. You can also ask your doctor. We know that chronic use of sleep medicine, even though it's really important to sleep, is bad for people. I'm not saying this. Here, you say this. Say Benadryl.
Yes.
Thank you.
Yes.
Yeah, so you can look them up. You know, our liver is metabolizing things. Our brain is trying to sort things out. Like, we do need medicine. We are blessed to have access to medical care and to have medicines that will reduce symptoms and improve the quality of our life. It's just that even though we have a, in theory, universal medical record, sometimes doctors are not looking at what other people are taking, and then we're taking a medicine and we get a side effect, and then we take a medicine for the side effect. That's called a cascade. And then we take something for the side effect of the side effect medicine, right? And sometimes you just have to have somebody that you care about and trust and feels like listens to you, and things can improve.
Side effects.
Mm-hmm.
Side effects get you all sorts of crazy feelings, and sometimes you don't even know who you are. And
Can be true.
it involves what you can do physically sometimes.
Mm-hmm.
And it is awfully hard to get, especially new medications, to find out what the side effects really are. And it's impossible, having had a husband who had 2 new medications, and they just ignored the fact that they could have been interacting just because they were new.
Frustrating.
It took
Super
months.
frustrating,
And
yes.
it's awful.
I agree. I'm sorry you had that experience. Not uncommon. True.
More questions?
Pat Guthrie. Lay it on me. I'm right here.
Is there a good website to find out side effects of medications besides Google?
I don't know. That's a great question. You know, the thing about, and again, I have to be really careful not to pretend I'm a doctor. The thing about side effects is when they do a drug trial, it's my understanding that a person has to write down every single thing they experienced. So you're taking a medicine X and you're reading in the side effects. Medicine X might be for arthritis. I have arthritis in both my feet. But you are throwing up. Well, the person, 5 people in that study got the stomach flu and 2 had food poisoning, so it has to go in the list. You should read, who is going to read those? Those 27,000 page whatever, nobody reads them. I always say to my doctor, tell me the top 5 side effects you see when you use this medicine. I'm interested in that, but Pat, you and I should create a website for all the side effects. I don't know, I'll think on it. Oh, thank you. Oh, thank you. Should I pass it around?
Yes.
Okay. This is the journal. Thank you. This is the journal I wrote for people. I have a couple of them. I'll pass a couple around. Thank you for saying that.
While this is going around, are there more questions? Yes, Gail has a sign-up sheet for the free newsletter, and there's one on the counter back here. So don't forget to sign up if you would like to receive that.
They're
Thank
not,
you.
they're not bound like this plastic one. These are just examples. They're soft cover or hard cover.
Thank you so much, Dr. Schaefer.
Thank you for letting me come.
Very
Thank you so
informative.
much. I
Appreciate your being
appreciate
here.